I wanted to go back to or kind of go on to the next question was this idea of kind of research and the importance of understanding the literature. And I will say, I don't know if I've ever told you this, Larry. So I remember there was a CFHA in Charlotte. I want to say it was like 4 years ago. And Jeff Ryder and we were giving a presentation about an overview of the literature on PCBH. And I remember talking to Jeff before, and he's like, hey, Larry's coming to this presentation, like, we gotta have everything together. Like, we have to have this. And I remember it was probably, I mean, I always get nervous for my presentations, but it was definitely probably the most anxiety-provoking presentation I had done up to that point, where I saw you in the audience. I was like, oh man, we got to do a good job. So I think, though, it highlights, I mean, and this is what I always love about our conversations, because we always do eventually get to what is research saying. And you served, obviously, as the editor of Family Systems and Health. So I think I have two questions for you. The first one is, why do you think it is so important for, whether you're a clinician, whether you're in academia, whatever it is, for whoever's working in integrated care, to be so kind of on top of the current literature? Why is that important to you?
Because healthcare in general is renowned for using and advocating strategies that end up not being beneficial, costing more money, and in some cases doing harm. There are lots of ideas out there, and often we get so carried away with our own ideas or things that seem useful that we don't stop and think, is this really making a difference? And is it cost effective? Is it safe? And this is not just about integrated care. There are just, you know, myriad examples across all of healthcare, not just in mental health. So I think it's really important that we ask ourselves: is what we're doing making a difference? Is it added value? Is it making the best use of resources that we have? Is it making a difference for the populations that we're serving? That's why I think it's important. So it's very easy for people to get carried away with their own ideas and to sell them, and for people just to sort of follow them off a cliff without actually thinking, is what I'm doing now really the best use of my time? That's a pretty broad statement, and I don't know if you want me to get more specific or not. But
well, you know, I might ask you to get a little bit more specific, because, you know, I know, what was it, Larry? Was it two years ago when you wrote the editorial? And I think it was such an interesting time, and particularly about PCBH, right? About primary care behavioral health, and it was such an interesting time. And it's still an interesting time, I think, for primary care behavioral health, and even what that means, and what is the research saying about primary care behavioral health. And the one thing that we have talked about regularly is that, you know, going around the country, talking with other people, getting to consult with other programs, and going on site, there is such a variety of what even primary care behavioral health is. And it is always that good question, like you said, like, since integrated care has been almost so uptaken and it's being so promoted right now, it has in a lot of ways just been like, hey, anything that you do as far as integrated care is good. And that, I don't know if that's true. I don't know if that's true.
No, in fact, it's definitely, you know, I think it's definitely not true. And I think I know the editorial you're referring to. So the evidence does say that there are certain elements, irrespective of the model, that really make a difference. Primary care behavioral health is a very interesting term, and like in so many other cases, the name has now taken on bigger meaning. So primary care behavioral health, it's a model, but it's also a term that for many people, they don't really even know the literature. They just think, oh, this is behavioral health and primary care. And so let's just get out and do it. But there are some models, and the problems with models is that people sometimes get so engaged with just perpetuating the model, they don't stop and think is this making, a difference? So that paper that you're describing made the point that that the proliferation of the PCBH model far outstretched, and still probably does, the evidence to support it. And you and I have talked a lot about this, that there are people who are rigidly adhering to a very limited number of visits, irrespective of how sick patients are, and that's irresponsible. And they're not monitoring, or they're so preoccupied, for example, with seeing so many patients that they're not doing the other things that are shown to make such a difference, which is documenting symptoms, documenting what they're doing, communicating with other members of the team, measuring progress. They're forgetting to do that kind of stuff because they're so interested in just seeing as many people as they can. So they're losing sight of the forest for the trees. And in a similar way, people also read literature and they say, well, this model, for example, the collaborative care model, is only works because it's applied for people with depression. Well, common sense would suggest that actually there are a lot of things that transcend diseases. We know that most people who suffer from depression also have anxiety, and vice versa, and it goes beyond that. So certain principles that we've learned that transcend diseases, and people don't stop and think about that either. So reading the literature, I think, and really understanding it, and understanding how populations respond to usual care without added intervention is very, very important.
Larry, I couldn't agree more with you. And I think, and because I've seen it, I know we've talked about it, where even going to a health system and it's like, well, we implemented this model and we're not getting the results that we wanted. And it's kind of like, well, let's look at what you're implementing here. And as you said, it's like this rigidity of number of visits, how long visits can go for, what you're supposed to help with and what you're supposed to see. And it is one of those things that I think it's an interesting, I think it's a fun time, because like, as you said, there are things that we're starting to see that transcend these models and that coalesce, so we can really start to help programs implement. And I know this is, again, it's a corny as hell thing to say, but one of the things I've always admired and always appreciated about you is your willingness to say that. Your willingness to say maybe something that might go against, it might make a lot of people potentially it's like, well, what are you talking about? Of course, primary care behavioral health has like this research base. And of course, and I have always really appreciated that about you, that you're willing to have that discussion. It's not something that has been shied away from. So thank you for always being willing to do that.
Yeah, well, it became very apparent to me as an editor where I felt a real responsibility to monitor as a gatekeeper what got out of the literature. And there were just many, many publications that were submitted where people did not acknowledge usual care, and so they weren't comparing what they were doing to anything. And they didn't understand that a large proportion of the changes that they saw probably would have occurred had they done nothing. And there's good evidence to show that. So and this again is not new to primary care behavioral health or the integrated behavioral health world. Healthcare providers who want to promote what they're doing across all disciplines have been doing this kind of thing for a long time. And that's the reason why you see the promulgation of these very strong evidence-based organizations that are designed like the Cochrane Collaborative to assess evidence and make a difference. That's why the U.S. Preventive Task Force came into being.
Amen. Amen. Now, speaking of which, as being editor, what do you, thinking back at your time as editor, what were the most interesting or articles that you read or literature that you reviewed that made you, thinking back on that now, you remember those articles or you remember that literature? Is anything stand out? It's like, oh man, that was like a seminal piece of work, or like, man, we really thought we were onto something, and then that got blown out of the water for research? I mean, anything that comes to mind as you look back on being editor?
Well, gosh, there's so many. It's hard for me to think about one because there are so many different articles, but I think you want me to respond to the dimensions just within integrated care. I think there's been a really good effort to publish some studies which take an honest look at what the components of integration are, and if those are associated with better outcomes. And I think we published some of those. The PIP studies that Roger Kessler and his colleague Dan Mullen and others have done. I think those are some examples. I think that there are some studies that show that the size of a population that actually gets preventive care, the component of a population that gets preventive care, that gets assistance in managing their chronic medical illnesses, is increased by the addition of well-integrated behavioral health. That stuff I think is really important. So those are good examples. As we've already discussed, the studies that concern me the most were those where the authors cherry-picked the literature, where they didn't take a bigger look at really what the literature showed, where they ignored, because they were so allied to a given model, they ignored evidence from broad population samples, which were overwhelmingly useful, just because they wanted to support a model. So those were the studies that concerned me, and I often either rejected or demanded that the authors change what they wrote.
And I think it's always this interesting thing, because I know I've been guilty of that, and a lot of times, as you said, kind of this cherry picking. It's one of the heuristics, right, that we're bound by. It's like, as soon as something fits my worldview, let's use it. If that doesn't, there's something wrong with that study, so I'll need to include it, right? And I do think, I guess this is almost my call to action for people doing this work in integrated care, even if you're a clinician, that there is such an importance of making sure that, one, we get the work out there, but we get the work out there in the context, in the system of including all these different components and making sure that we are being, as much as possible, we're always going to be biased, but as much as possible, taking an unbiased view of looking at the work that we're doing, for sure.
Yeah, and one of the things that people often who are trying to write forget is writing a really well-constructed limitations section if they're doing research. And that's a very humbling but helpful thing to do. Why is it that what I've just presented may actually not be true, or may be limited in its application or generalizability? And a thoughtful a limitation section, is sobering for the reader. And when you really think about that carefully, it should be sobering for you as a writer and cut back your tendency to want to promote. And I remember being, seduced by this early on in my career too. It can cut back in your tendency to want to kind of overstep the evidence that you're trying to present, overemphasize or oversell. And we're, I don't want to get off on COVID, but we're learning that, as you and I were talking about before we started this recording, it seems like the evidence that we're learning actually is changing day to day, and I think it's obviously slower in integrated behavioral health and primary care, but the same thing is true.
Yeah, and I like the word again that you use, that humility to it, and I will say this is again another thing that I've always appreciated about our conversations, because this is why I love sending you our data, because you do such a great job of kind of sending back. It's like, have we thought of this? Like, what else could this be coming through? And I think some of the interesting data that we're getting about our diabetes results is more about patient engagement, not necessarily about the behavioral health provider necessarily doing something that is really help, like a one-to-one intervention of like, oh, the BHC, and then now their diabetes management gets better. It's more looking like BHC and their engagement with the health system goes up. So again, it is that curiosity, that humility to always be skeptical of even the stuff that, especially when it's exciting things, right? Especially when you get the results you want, to be really skeptical about that.
Yeah. We have to always be asking, what other explanations are there for this change, this success, or these failures? I learned early on that good research generates more questions